Welcome to this explainer. Today, we're cutting straight through the noise. We've compiled the absolute best quality scientific facts and data for this explainer, making it the perfect, highly informative video to share on YouTube or with anyone navigating these challenges. We are cracking the code on two of the biggest hurdles in reproductive health: endometriosis and polycystic ovary syndrome, or PCOS. So let's jump right in.
Here's the core question we are tackling today. How exactly does science solve the infertility puzzle? When a patient faces these really complex reproductive roadblocks, doctors aren't just guessing. No way. They rely on massive, high-quality datasets, comprehensive guidelines, and rigorous comparative studies to build a totally personalized roadmap. Today, we're putting on our clinician hats and looking at the exact same data they use to make these life-changing decisions.
Here is our roadmap for today. We're looking at the infertility puzzle, diving into endometriosis, medical versus surgical, and its role in IVF. Then we'll pivot to PCOS first-line treatments, advanced medical options, and finally, tailoring the fertility journey. Let's get into it.
Section 1. The infertility puzzle, defining the challenges. Before we get into the treatments, we have to lay down exactly what specific physiological roadblocks we're up against. It's honestly wild how different these two conditions are, even though they both share infertility as a main symptom. Endometriosis, which affects roughly 6 to 10% of reproductive-aged women, is a chronic, estrogen-dependent inflammatory issue. It's basically endometrial-like tissue growing where it shouldn't, outside the uterus, which distorts the pelvic anatomy and causes severe pain. On the flip side, PCOS is a totally different beast. It's an endocrine and metabolic disorder defined by insulin resistance and excess male hormones. Astoundingly, PCOS accounts for about 70% of all anovulatory infertility cases. Two completely different mechanisms that need entirely different approaches. Section 2, endometriosis, medical or surgical, weighing pills versus procedures. We're pulling our facts straight from a massive 2025 systematic review of 38 comparative studies here. This medical versus surgical route has been fiercely debated for ages. Medical treatments, like GnRH analogs or birth control, they're great for pain relief. But here's the catch. They basically act like contraceptives during the treatment. They just hit pause on the whole system. But surgery, usually via laparoscopy, actually goes in, removes the lesions, and works to restore the normal anatomy. So if your goal is spontaneous, natural conception, these two paths give you wildly different outcomes. Okay, look at this number, 1.71. According to that 2025 meta-analysis, surgical treatment carries a pooled odds ratio of 1.71 for spontaneous pregnancy. To put that in a plain English, if a woman has mild to moderate endometriosis and gets the surgery, she's literally 71% more likely to conceive naturally than someone who doesn't. The data heavily favors the surgical path if unassisted conception is the goal. Section 3. Endometriosis and IVF, the role of pre-treatment. But hey, what happens when natural conception isn't the immediate plan and a patient is moving toward IVF? Here is where we get a massive plot twist in the data. You know how surgery was the clear winner a second ago? Well, if you're gearing up for an IVF cycle, surgery actually does not show a significant bump in live birth rates compared to control groups. Actually, repetitive surgeries might even risk hurting ovarian reserves. But medical pretreatment, using those suppressive meds before an IVF transfer, that actually gives you a solid clinical edge. It bumps up pregnancy rates with an odds ratio of 1.27. So it's like surgery to conceive naturally, but medical suppression to prep the soil for IVF. Makes total sense, right? Moving to Section 4, PCOS first-line treatments, starting the journey. Let's switch gears smoothly over to PCOS, using the latest, validated FOGC consensus guidelines to map this out. FOGC gives us this really clear, evidence-based ladder for treating anovulatory infertility in PCOS. Step 1 is, across-the-board, lifestyle modifications. Before any prescriptions are ever written, exercise and diet are just absolutely critical to fix that metabolic foundation. If that doesn't jumpstart natural ovulation, Step 2 is pharmacological, and letrozole takes the crown here. And if meds fail, Step 3 is assisted reproductive technology, specifically IVF. The clinical algorithms map this exact progression out perfectly. Letrozole is the undeniable first choice now. For the longest time, clomiphene citrate was the go-to drug. But modern data proves letrozole not only boosts clinical pregnancy and live birth rates, but it actually drops the risk of having multiple pregnancies, like twins or triplets, and lowers the risk of hyperstimulating the ovaries. It's just a much safer, far more effective starting line.
Section 5. PCOS Advanced Medical Options, Second-Line Therapies in Synergies. So what happens if letrozole just isn't cutting it?
Let's unpack the pharmacological toolkit here. Letrozole, as we said, is your first-line aromatase inhibitor. Clomiphene citrate got bumped down to second line because of those multiple pregnancy risks we just talked about. Then you've got gonadotropins, which are injectable hormones. They're also second line, but you have to monitor them incredibly closely because of the high risk of OHSS, where the ovaries basically over-respond. And finally, metformin and myoinositol. These are insulin sensitizers. Now, they aren't just for diabetes. They are absolutely crucial players in fixing the underlying metabolic engine for PCOS.
Actually, there is this fantastic quote from the FOGSI clinical trials data I have to read to you. Since the two insulin sensitizers, MI-FAMA and metformin, function via different mechanisms, combining them may yield synergistic effects. And wow, does the data back this up. When you combine these two over a 6-month period, the pregnancy rates just skyrocket compared to using metformin by itself. One study saw a 43% pregnancy rate with the combo versus just 26% with metformin alone. I mean, that is a massive 1-2 metabolic punch.
Section 6. Tailoring the fertility journey, bringing the data together. We've thrown a massive amount of clinical data your way today. From surgical odds to metabolic synergies, let's synthesize all of this.
Here are your rapid-fire takeaways, the concrete scientific framework you should walk away with. For endometriosis, surgery is your best bet for a natural conception boost, but medical suppression is the way to go for IVF prep. For PCOS, lifestyle changes anchor everything. Letrozole is the undisputed winner for first-line ovulation meds, and combining myoinositol with metformin creates an incredible metabolic synergy. And for both dysphint conditions, IVF stands strong as a highly effective, safe third-line option. Which brings us to our final thought. Seeing the hard data laid out like this, how does it change your perspective on personalized fertility care? The path to pregnancy isn't a guessing game at all, is it? It's a meticulously calculated scientific puzzle. Having access to these high-quality facts gives patients their power back. Thank you so much for joining me on this explainer. I hope you found this deep dive into the data as fascinating as I did. Keep learning, stay curious, and I'll catch you next time.